Greetings from Indian Journal of Anaesthesia. I, Dr. Kiran Mahendru, will present a randomized comparative study published in the December issue. It is a study on comparison of fiber optic guided tracheal intubation through LMA Protector and IJA in adult paralysed patients. Second generation supraglottic airway devices are not only being used as a ventilating device, but also as a conduit for blind as well as fiber optic guided intubation in anticipated or unanticipated difficult laryngoscopy. The literature is not supportive of blind intubation through the supraglottic airway devices because of limitations such as need of multiple attempts, less success rate, increased time, esophageal intubation, and airway trauma. Fiber optic guided tracheal intubation through these devices is well described. The airway channel of IGEL device is shorter and wider than the other supraglottic devices, allowing the adult size endotracheal tube to pass through it easily. The absence of aperture bars, large bowel, and better alignment with the glottis makes IGEL a favorable conduit for fiber optic guided tracheal intubation. The larger airway lumen of the laryngeal mask airway protector allows adequately sized tracheal tube and thus is a suitable conduit for fiber optic guided tracheal intubation as well. The authors planned the current study to compare the fiber optic guided tracheal intubation through IGEL and LMA Protector using PVC endotracheal tube. The primary objective of the study was to assess the time to tracheal intubation via the two supraglottic airway devices, and the secondary objectives were the insertion characteristics of the device, that is, the number of insertion attempts, mean time of insertion, ease of insertion, success rate, and oropharyngeal leak pressures. The intubation characteristics, like the fiber optic view of placement, the time to view the carina, number of attempts, and ease of procedure, and any adverse events. The hypothesis of the study was that the time to fiber optic guided tracheal intubation using a PVC ETT will be similar between the two supraglottic devices. Ethical approval was attained and the trial is registered with CTRI. It is a randomized comparative study conducted between March 2023 to November 2023. It included 66 patients from 18 to 70 years with an ASA physical status of 1 or 2 scheduled for elective surgery under GA. The patients excluded were with known difficult airway, BMI of more than 35, edentulous patients, interincisor distance of less than 3.2 centimeters, pregnancy, surgical procedures involving the oral cavity or procedures in prone position, and patient's refusal to give the consent. During the preoperative visit, the purpose and protocol of the study were explained to the patient. Appropriate fasting guidelines were followed as per the institution protocol, and standard ASA monitors were used. A computer-generated block randomization list was generated, and group allocations were concealed in numerically ordered sealed opaque envelopes. Patients were randomized to one of the two groups, that is, group LP or group IG. Fiber optic guided tracheal intubation was done through LMA Protector in the group LP and IGEL in the group IG, respectively. All patients were pre-oxygenated to achieve the end tidal oxygen concentration of more than 90. Induction of anesthesia was done using glycopyrrolate, fentanyl, propofol, and nitrocurium. And the maintenance was done with oxygen, nitrous oxide, and isoflurane to keep an age-adjusted end-tidal volatile concentration of 1 mAc. Both device sizes were chosen as per the manufacturer's recommendation. Size 3 for patients less than or equal to 50 kgs and size 4 for 51 to 70 kgs. Depending on the group allocation, LMA Protector or IGEL was inserted as per the manufacturer's instructions. The correct placement of the supraglottic airway device was confirmed by leak-free ventilation, which achieved a tidal volume of more than 6 ml per kg and a square wave capnograph trace. During the procedure, the insertion time, measured from picking up of the device to the appearance of the first capnography trace, number of attempts at insertion, and ease of insertion, where easy insertion was 1, moderate resistance was given 0.2, and severe resistance was given 0.3 were recorded. Device insertion was considered a failure if the end tidal capnography could not be obtained or adequate tidal volumes were not achieved with inspiratory pressures of 15 centimeters of water. A maximum of 2 attempts were allowed, and if unsuccessful after 2 attempts, it was considered a failure and the airway was managed using an alternative device. The oropharyngeal leak pressure was noted. This was done after confirming proper device placement. Patients were shifted to the manual ventilation mode. The APL valve was fully closed and the oxygen flow was maintained at 3 liters per minute. Pressure at which audible leak occurred, or up to maximum pressure of 40 centimeters of water, was noted as the oropharyngeal leak pressure. A flexible fiber scope loaded with a PVC endotracheal tube with an internal diameter of 6.5 mm for female or 7 mm for males was introduced to the lumen of the supraglottic devices and advanced into the trachea. As the tip of the fiber scope emerged from the channel of the SAD, the grade of glottic view was recorded on a scale of 1 to 4 as described by Brimacombe and Berry. If the vocal cords were fully visible, it is given 0.1. Vocal cords partially visible or arytenoid cartilage visible is 2. Epiglottis visible is 3. And no structures visible is 4. The outcomes assessed were the time to view the carina, that is, time from insertion of the flexible fiber scope into the SAD to the visualization of carina. The tracheal intubation time from inserting the flexible fiber optic into the supraglottic device until the appearance of the first capnography trace. Number of attempts at tracheal intubation, total intubation time, and particular difficulties such as tracheal tube impingement needing rotation and ease of procedure as judged by the operator on a 10-point VAS scale. After the intubation via supraglottic devices, it was left in place until the end of the surgical procedure. The cuff was deflated in cases where LMA Protector was used. After adequate recovery from the neuromuscular blockade, the supraglottic devices and ETT were removed simultaneously and the patient was shifted to the PACU. At the time of removal of the device, any blood staining of the device or trauma to tongue, teeth, gums, or lips were noted. Patients were also inquired about complaints of sore throat, dysphagia, hoarseness of voice at 1 and 24 hours after removal of the device. The sample size was calculated as per the based on tracheal intubation time from a previous study and with 95% confidence interval, 80% power and an alpha level of 0.05. Considering a 10% dropout rate, the authors enrolled 66 patients. SPSS 27 was used for statistical analysis with tests, chi-square test, Fisher's exact test, independent student T test, and Mann-Whitney U test applied. This is the consort checklist in which 70 patients were recruited as per the inclusion and exclusion criteria. 4 were excluded because of lack of consent and 66 were randomized into either group LP, that is LMA Protector, or IG, which is the IJA group. The demographic characteristics of the patients, which included age, weight, BMI, gender, ASA physical status, and the duration of anesthesia, were comparable between both the groups. The airway assessment parameters of the study population, which included the MP grade, the thyromental distance, jaw protrusions, the size of device used, and the neck movements, were also comparable between both the groups. Now coming to the comparison of clinical performance of the two studied supraglottic devices. The time of insertion of both the supraglottic devices were comparable the number of insertion attempts, the ease of insertion, the oropharyngeal leak pressure, fiber optic view grading, time to view the carina, tracheal intubation time, total intubation time, number of attempts of intubation, tracheal tube impingement, and ease of the procedure were all comparable between both the groups. The authors did not observe any statistically significant difference between the two groups in the fiber optic guided tracheal intubation time, fiber optic view grading, and the supraglottic insertion characteristics. In the present study, grade 1 and grade 2 glottic views were achieved via both supraglottic devices in most of the cases. Other related studies of tracheal intubation via supraglottic airway devices also show that once placed adequately, there is generally a good glottic view. Success rate of fiber optic guided tracheal intubation through IGEL and LMA Protector is comparable to that reported in the literature for IGEL, which is 91 to 100%. In the present study, they had 3 failures to intubate as no glottic structure was visible. 1 was in the IGEL group and 2 were in the LMA Protector group. Although the leak pressures were around 30 to 40 in all 3 cases, no glottic structure could be identified in these cases. The surgery completed using the supraglottic devices only, and no untoward event occurred during the intraoperative period in these 3 cases. Tracheal tube impingement that was overcome by anti-clockwise rotation of the ETT occurred more frequently with IGEL than with LMA Protector, but this was not statistically significant. No difference in insertion characteristics such as insertion time, the ease of insertion, or number of insertion attempts were noted between the two studies. The oropharyngeal leak pressure of LMA Protector was comparable to that of IGEL, and adverse events like blood stains on the device, trauma to the oropharyngeal structures, and sore throat were insignificant between the two groups. The limitation of the present study is that patients with anticipated difficult airways and those with BMI of more than 35 were excluded. Thus, the performance of these two devices as a conduit for fiber optic guided tracheal intubation in this subgroup of patients cannot be generalized. Therefore, to conclude, the LMA Protector and IGEL are comparable conduits for fiber optic guided tracheal intubation using a PVC endotracheal tube in adult paralyzed patients. Thank you.